Today's topic is lower back pain, specifically how it should be diagnosed and addressed by primary care physicians. Introducing our presentation today is Dr. Tom Cavan, Medical Director for the Clinically Integrated Network of Seton Health Alliance and its pediatric sibling, Dell Children's Health Alliance. At Seton Health Alliance, we are always looking for ways to enhance the value of healthcare in Central Texas. Providing resources to our physician members is one way we can do that.
Hello, I'm Dr. Tom Cavan, Medical Director and Chief Medical Officer of Seton Health Alliance. Today we're going to talk about back pain and ways you can both diagnose and treat it. It's estimated in the United States that there's 149 million workdays lost every year to back pain. We're going to talk about some ways to really impact that very favorably. As primary care physicians, you know all too well that many patients come to you asking for MRI imaging, medications, other modalities that really may be unnecessary for their case. So we're going to talk about how to discern who are the patients who need more advanced imaging. We're lucky enough to have with us today Dr. Mark Queralt. For the last 20 years, Mark has specialized in the treatment of spinal pain and injuries. Today, he's the clinical leader of the back and neck program at UT Health Austin, part of the Mulva Clinic for the Neurosciences at Dell Medical School, as well as the Musculoskeletal Institute. Mark, can you start us off?
Thanks, Tom. I'm happy to be here today. I want to empower primary care physicians to confidently and knowledgeably approach back pain with their patients. Let's begin by taking a look at how most patients asking for treatment of back pain can be grouped. First, less than 1% have specific red flag pathologies that must be addressed urgently, like cancer or infection or Queralt syndrome. The next big bucket falls into, let's say, about 10% of patients, those with less serious but specific causes for their symptoms like radiculopathy, lumbar stenosis, or compression fracture or ankylosing spondylitis. But the clear majority of patients, in fact 90%, are classically thought of to have non-specific low back pain. However, at the end of this video, you'll be able to 1. Classify low back pain, 2. Understand how to perform a diagnostic physical exam, 3. Know when to image, 4. Develop a treatment plan, and 5. Know when to refer. Anatomy. Let's start with a little anatomy refresher. As you may recall, the lumbar spine has a natural lordotic curve. The spine is looking forward, the back here. The vertebrae in front, L1, L2, L3, L4, and L5, with the sacrum below. In the back are the facet joints, 2 at every level, and the spinous process. The nerves are encased in the central canal and exit in pairs at every level. The spinal cord typically ends around L1-2. After that, the nerves are hang in individual nerve rootlets. I tell my patients it's like a sack holding nerves hanging like spaghetti in fluid that exit in pairs at every level. Okay, now it's time to take a history. Cancer is rare, although it's probably a patient's primary concern. The only risk factor that has been shown to be significant is a personal history of cancer. Infection should be considered with severe pain, usually associated with systemic symptoms, and especially in the immunocompromised. The pain from fractures is also severe and focal. In the elderly, due to osteoporosis, a lesser trauma can result in a compression fracture, so think about age-related force. And of course, any rapidly progressing symptoms are worrisome, especially in the presence of objective neurological loss. Queralt syndrome is rare, but it is a surgical emergency. It is characterized by marked neurological loss, including bilateral lower extremity weakness, saddle paresthesia, as well as acute changes in bowel and bladder function. With the red flags excluded, it's time to classify. Here are the key points to consider when taking a history. Age. Younger patients are more likely to have a herniated disc, while older patients are more likely to have facet arthritis, lumbar stenosis, or spondylolisthesis. Onset. More than 3 months of persistent pain increases the suspicion for a chronic pain condition. Location. If there are referred symptoms, is the pattern of pain dermatomal, consistent with a nerve root compression? Character. Acute inflammatory pain typically is described as sharp or shooting, as opposed to chronic pain, which tends to be more dull, burning, aching, tight, or tense. Aggravating and alleviating activities are the most important elements from a classification standpoint, and we'll be going into more detail next. And of course, neurological symptoms, especially if worrisome, should always prompt you to the possibility of a red flag diagnosis. Flexion, or forward bending of the lumbar spine, includes such things as sitting, bending, driving, or squatting. Flexing increases pressure in the anterior column of the spine, and so would be expected to aggravate pain coming from discs, but also from vertebral bodies in the case of a compression fracture. Going for loading the disc in front. Extension or backward bending includes activities such as standing or walking. This loads or increases pressure in the posterior column of the spine and would be expected to aggravate pain coming from the facet joints as well as stenosis. Low back pain is defined by its response to movement and load. Most basically, its response to flexion and extension that should have opposite effects. If flexion aggravates, then extension should relieve or have no effect. And conversely, if extension aggravates, then flexion should relieve or have no effect. A non-mechanical pattern can be defined as one, as the title suggests, has no pattern. Pain can be constant, or if it's intermittent, it can be spontaneous or have inconsistent responses to activity. Movements of the body do not have a consistent or predictable aggravating or alleviating response. So think headache. Although less likely, you should also consider abdominal or pelvic processes, malignancy, or rheumatologic conditions. And also it's important to note that in the initial hyperacute phase, pain may present in a non-mechanical pattern. However, within weeks, if present, a mechanical pattern should emerge. Putting this all together, we see three basic classifications based on aggravating activity. Those worse with flexion, commonly seen in disc pain as well as compression fractures in the right clinical context. Those worse with extension, commonly seen in the older population with lumbar stenosis, facet syndrome, or spondylolisthesis. And those with no pattern, which is most commonly occurring in chronic pain, but may also occur in non-spinal conditions.
In this next section, Dr. Queralt is going to walk us through a 2-minute basic spine exam covering all the musculoskeletal and neurological processes that are important in assessing the back in a way that you can model it so that a primary care physician can use this as their basic back exam.
I'm now going to demonstrate a physical exam, which should be able to be completed within a few minutes. Before we start, 3 key tips. Number 1, pay attention to the nonverbal cues. Number 2, focus on asymmetries, especially during the neurological portion of the exam. And 3, when pain occurs, ask whether this pain reproduces their chief complaint or produces a different pain, either in a different location or of different quality. For the heel walk, I frequently offer to hold the patient's hand, especially if they are elderly or fearful. Weakness of ankle dorsiflexors may produce a foot slap or a foot drop. Weakness of ankle dorsiflexors may occur in L4 or L5 radiculopathies, as well as perineal neuropathies. For the heel raise, I have patients hold onto the wall for support, stand on one leg, and lift the heel 3 times. I always stay within arm's length for patient safety. Weakness of heel raise can occur in S1 radiculopathies. For the inspection part of the exam, I'd like to make 2 points. 1, it's always a good idea to ask patients permission before you lift the shirt and palpate the spine. And second, respect the patient's personal space. I always like to sit down for this part of the exam. If you stand, you may want to stand to the side. Please face away from me. May I lift your shirt and touch your spine? You may. I usually palpate in prone. However, since this abbreviated exam excludes the prone component, it's probably most efficient to palpate while they're standing here. From a clinical standpoint, palpation is probably the least informative part of the exam. However, from a patient perspective, it's probably the most important. I can't tell you how many times I've heard a patient complain that that doctor never touched my back. Does this hurt? Nope. For bending, I typically note range as to the floor, to the ankle, to the mid-leg, to the knee, or to the thigh. Bending will aggravate pain coming from discs as well as compression fracture in the right clinical picture. Now bend forward as far as you can go. I typically observe the spinal excursion and arise. Did that cause any pain? No. Extension I document as full for age or limited in a mild, moderate, or severe degree, which is very provider subjective. Extend backward as far as you can go. Extending typically aggravates pain coming from the facet joints, lumbar stenosis, or lumbar spondylolisthesis. There is a 0 to 5 point motor scale. Just remember 0 to 5 is no movement. 3 out of 5 is full range through gravity only, meaning the muscle cannot move against any resistance. And 5 out of 5 is normal strength. I'm going to test your strength now. Please give me your best effort. Even if it's painful, try to give me at least a second of your best. Here, leverage is really key. I try to use my body to get maximal effort. Lift your knee up as strong as you can go. Weakness of hip flexors can occur in upper lumbar radiculopathies, most commonly L2-3. Straighten your knee out as hard as you can go. Again, I use my body as leverage. Weakness of knee extensors can occur in upper lumbar radiculopathies as well, more commonly L3 and L4. Lift your ankle up as strong as it'll go. Weakness of ankle dorsiflexors can occur in L4 or L5 radiculopathies, as well as perineal neuropathies. Lift your great toe as strong as it'll go. Weakness of great toe extension, or EHL, can occur in L5 radiculopathies, as well as perineal neuropathies. We don't have to test S1 motor strength because we did that earlier with the heel raise. Dermatomal sensory testing tends to be the least reliable, as it is completely subjective. Does this feel the same on both sides? L3, L4, L5, S1, and S2. For reflex testing, technique is important. Make sure the legs are dangling. Use a bounce technique over the patella tendon. If you have trouble getting a response, distracting can help. I ask my patients to pull their hands apart like this, or alternatively make a fist. This can release the knee response, the knee reflex. For the ankle, slightly dorsiflex the ankle to neutral to get the best response. Loss of knee reflexes can result from an L4 radiculopathy. Asymmetrical loss of ankle reflex can result from an S1 radiculopathy. Although it's not uncommon to lose both ankle reflexes in the elderly due to multifactorial peripheral neuropathy. If the history suggests claudication, that is leg pain while walking, it's good practice to check for pulses. If the history is not suggestive for claudication, simply checking for symmetry in color and temperature is likely enough. For all provocative maneuvers, try to avoid explaining what a positive test produces. In other words, instead of asking, does this produce pain down your leg, ask, where are you experiencing pain? It's also important to note whether the pain experienced reproduces their chief complaint or produces pain in a different area or of different quality. I test hip range of motion using the classic Faber, which stands for flexion, abduction, and external rotation. I follow this with hip internal rotation and use overpressure as necessary. Hip testing is important to determine the contribution to the hip from the hip to either low back, inguinal, or anterior medial thigh pain. A straight leg raise is considered positive when it does two things. One, it reproduces their posterior thigh pain, and two, it does so within a range of between 30 and 70 degrees. Less than 30 degrees is not thought to create enough nerve retention to aggravate radicular symptoms, and pain experienced beyond 70 degrees stresses muscular tissues as well as the hip. For the 2-minute exam, we could stop here. Since upper lumbar radiculopathies, those involving L2, L3, or L4, are relatively uncommon, accounting for less than 10% of all lumbar radiculopathies, a prone exam is not always necessary. However, if a patient complains of inguinal, anterior, or medial thigh pain, it's best to perform a prone exam. A femoral stretch is performed by passively bending the knee. A positive test occurs when pain is reproduced in the anterior medial thigh. Again, the quality of pain in acute radiculopathies tends to be sharp, acute withdrawal type pain, as opposed to pulling or stretching, which is relatively common with tight muscles. Although we explain performing palpation while standing, in my practice, when the patient is prone, this is where I typically perform my palpation. Okay, this concludes our exam. Let's sit down and talk about what this all means. After completing the history and physical exam, it's time to make your assessment. First, rule out any red flags we reviewed earlier. Second, stratify the patient's low back pain according to the movement pattern, by history and corroborated by your exam. As you recall earlier, there are three basic categories. Those aggravated with bending forward, suggested for disc or compression fracture in the right clinical context. Those aggravated by bending backward, common in facet syndrome, lumbar stenosis, or spondylolisthesis. And the no pattern bucket, which most commonly reflects chronic pain. However, you have to consider non-spinal etiologies. Pain and loss in function are the primary drivers of more aggressive intervention. With an intact motor exam, you can be pretty confident to recommend a conservative approach. Finally, consider the psychosocial contribution. Psychosocial factors influence all pain presentations. You should consider depression, anxiety, history of abuse or trauma, other mental health illnesses or stressors, and social factors. Now, a quick look at chronic pain. In the case of structural pain, patients have typically been dealing with symptoms for less than 3 months. The trigger was an inciting event. The pain comes and goes and tends to be more sharp or electrical. And most importantly, it tends to have specific aggravating and alleviating activity, as we've been talking about. Chronic pain we attribute to the nervous system, and we use the word sensitization. It is very different. The patients have been dealing with pain for more than 3 months. There's usually not an inciting event, or if there is, the pain lasts longer than would be expected by the natural history. The quality of pain is frequently described as dull, burning, aching, tight, or tense. Pain may be constant. If intermittent, then it is frequently spontaneous or unpredictable. Importantly, there is no consistent aggravating or alleviating activity. With acute structural pain, most patients respond to time alone. In fact, 85% of people with acute low back pain improve within 1 to 2 months regardless of intervention. On the other hand, treatment of chronic pain can be challenging, and it's outside the scope of this video.
In primary care practice, very commonly patients present requesting MRIs, CAT scans, other advanced imaging, or medications, which may not be indicated, may actually be counterproductive. Here in this next section, Dr. Queralt is going to give advice on how to determine who are the patients who might need this advanced imaging and who are the patients who don't and need more conservative management. As a primary care physician myself, I really wish I had had access to a very skilled back pain specialist like Dr. Queralt.
Yes, Tom, the key point is that the clinical impression is made by the history and physical exam, so imaging is usually not needed. In fact, guidelines do not recommend X-rays in the first 4 to 6 weeks unless there are red flags. Patients should consider the risk. Lumbar X-rays are thought to have 15 times the radiation exposure of a chest X-ray. If you are to get X-rays, I recommend standing views, as spondylolisthesis can be missed on the supine X-ray.
I'm going to interrupt Mark for just a few moments. Seton Health Alliance, we feel very strongly about this issue. And as a primary care physician myself, I know how adamant patients can be about wanting advanced imaging. The cost of imaging, such as MRI, even CAT scanning, is very high. And more importantly, it's unnecessary and even can lead to overtreatment that in the long run does not benefit the patient. If you have any concerns about your patient's condition, I think a very good strategy is to refer directly to a non-surgical back specialist like Dr. Queralt, a physical medicine rehabilitation physician.
You're right, Tom. MRIs should ideally be deferred to the specialist. Like I said, the clinical impression is based on the history and exam findings, so imaging is usually not necessary. Imaging findings are secondary and usually do not change management, especially in the acute phase, when conservative therapy is the mainstay. I often review this chart with my patients, which demonstrates the percentage of quote-unquote abnormal findings on MRI in healthy, pain-free subjects. Much of the time, these findings are really normal for age, like wrinkles, and are not clinically significant. By our 40s, around 40% of us will have disc protrusions, 50% will have bulges, and 70% degenerative disc disease. And the numbers go up from there. The first line of treatment is physical activity and a directed home exercise program. In the immediate acute phase, we recommend active rest, which means activity is tolerated. In fact, bed rest for more than 2 days is thought to be harmful. Home exercise programs are based on the patient's movement pattern. Those with a flexion aggravation receive a extension-biased home exercise program, and those with a extension aggravation receive a flexion-biased home program. For those with persistent non-mechanical presentations, you may consider an early referral to a specialist. Evidence for medication is limited. From both an anti-inflammatory and analgesic strategy, I frequently begin with scheduled over-the-counter nonsteroidals, in the absence of high GI risk or high cardiovascular risk. I typically recommend either ibuprofen 600 to 800 milligrams TID or naproxen 440 milligrams BID for 1 to 2 weeks as medically allowable. These can easily be purchased over the counter, and I give the patients verbal as well as written instructions. For acute radicular symptoms of greater severity and or unresponsive to an NSAID, I may consider a prednisone taper. Recent studies have shown the benefits of NSAIDs for pain. In fact, in one study, adults presenting to the emergency room for acute extremity pain severe enough to warrant x-rays, ibuprofen plus acetaminophen was found to be equally effective at reducing pain at 2 hours compared with 3 different opioid formulations. Physical therapy should be considered in those with a flexion or extension presentation that are unresponsive or incompletely responsive to their home exercise program and or medications. When referring to physical therapy, specifically request 3 things. Number 1, to evaluate for directional preference. This is the physical therapy term or language for the flexion and extension biases we've been talking about. Number 2, ask to prioritize active over passive care. And number 3, limit the initial program to 6 visits, then reassess. If patients aren't responding as anticipated, then consider a referral to a specialist. For those whose pain is non-mechanical or chronic recurrent, consider a multidisciplinary referral before physical therapy. Many patients are eager for a quick fix. It's important for patients to understand that for low back pain without radicular symptoms, procedural and surgical interventions carry a high risk for suboptimal outcome, meaning these interventions may not help and in fact may make the pain worse. Even with radicular symptoms, procedures and surgery are commonly elective. For acute radiculopathy, lumbar epidural steroid injections may offer short-term relief. The goal of epidural steroids is to allow the patient to participate more fully in physical therapy. There is limited evidence that epidurals change long-term outcomes. Additionally, recent studies have suggested that lumbar epidural steroid injections are not supported for lumbar stenosis unless there is a concurrent radiculopathy. When conservative treatment has failed, surgery offers hope to those desperate to improve pain and function. I don't know where I found this quote, but it's so true. The take-home message is to separate hope from facts and appreciate the psychosocial relationship to the pain experience. This concludes my presentation for today. I'd like to thank you for watching, and Tom, as well as the Seton Health Alliance, for having me here today.
Thank you, Dr. Mark Queralt. That was an excellent section. I know I learned a lot, and I feel confident my other physician, nurse practitioner, and physician assistant colleagues learned a lot as well. For more advanced knowledge, we are planning another series of videos with Dr. Queralt, which will focus on the very comprehensive back exam, more the kind of examination that he conducts in the Mulva Clinic. So stay tuned for additional videos in this series. Thank you.